Start the anthem.
Good afternoon, everybody. Ladies and gentlemen, welcome to this guest lecture series run by CAHO in association with JMitra. Our subject today is the prevention of transfusion-transmitted infections, TTIs, in Indian blood centers. And we have an eminent panel of speakers today, moderated by Professor Ashok Rattan. But before we go any forward, I'd like to hand over to the team from CAHO, and I'd request you to pay attention for the CAHO anthem. Over to you, Pramodji and Dr. Jairam.
New dawn, a new horizon of healthcare delivery and patient safety. We have a goal, a noble drive. Hand in hand, step by step, we will thrive. To march ahead together, a bright and shiny future with patient safety and quality healthcare. We are CAHO. Your healthcare companion, standing right by your side. Joining hands for building a vision, shaping a culture for patient safety. Setting up standards with best foot forward. Won't ever leave no stone unturned. We wear our pride on our sleeves. Work with passion like a breeze. Train people, enhancing their skills. Spreading the message of quality healthcare for safer patient care, a better nation. We have a goal, a noble drive. Hand in hand, step by step, we will thrive. To march ahead together, a bright and shiny future with patient safety and quality healthcare. We are CAHO, your healthcare companion, standing right by your side.
Well, that was one melodious anthem and interesting choice of music as well. Can we have the screen shared? And Dr. Jairam, I think the forum is yours for now. Please go
Yes,
ahead.
yes. So, thank you very much, Professor Ashok Rattan and the team JMitra and esteemed speakers. Just a couple of minutes before we get into this wonderful journey of Feast of Education today, wonderful topic. So we stand, as you saw in this quick small musical, for consortium of accredited healthcare organization. Our vision is to be an admired global leader, transforming healthcare quality and actually patient safety. So we are not an accrediting agency. We are a training body which works not for profit organization and working with focused events, courses, workshops, and training programs. We have various verticals like healthcare institutions, quality professionals, and this is under diagnostic center. So we have currently maybe around 97 such webinars hosted till now by my wonderful team. These are our patrons, Girdhar Gyani, Venkatesh Tupil. I think these are all our leaders and masters in quality in diagnostics and in healthcare overall. Can I have the next slide? So this is our Kaho Central team, Dr. Vijay Agarwal, Lalu Joseph. Pramod, you can just quickly go through the slides. Dr. Shankar and Nareen Sehgal. The next is our Kaho diagnostic team, where I am there along with Dr. Ravi Kumar, very reputed microbiologist from ex-NIMHANS, Dr. Vinita Kothari, a pathologist leading a chain of labs in Madhya Pradesh. Next. So this is the meaning of our logo. We have different verticals. We do many other things like nursing excellence, cyber security, biomedical engineering, you name it. And we are having many verticals under each of this branch. Finally, we are working towards patient safety. Yeah, so these are what our goals are: a safer patient care. That cannot happen without strengthening quality. We are promoting accreditation, sharing best practices, and creating benchmarks. Next slide. So, Pramod, you can keep on going ahead. I think we as Kaho team, we have Dr. Ashok Rattan, who is one of the eminent, no, he needs no introduction, but still the slide says it all. One slide is enough for sir. And I look up to him as my mentor, my person who guides me through this journey of, whole arena of microbiology and the latest developments. Sir has also helped us in starting a zoonotic series. He was a chair in our Kaho Diagnosticon in Delhi and the core team member in the next upcoming conference happening in Indore on 24th and 25th. And sir, I'm really happy to have you with me to take this journey and take diagnostics up to what's our dream up to last mile. So over to you, Professor Ashok Rattan, and all the very best for the delegates and JMitra. Thank you so much.
Thank you. So today we have we are fortunate to have two stalwarts in blood banking and blood screening of. And can I have the next slide? One of the person we come from the same medical college is Dr. Suchitra Jain. She's Associate Director and Clinical Administrator, Max Super Specialty Hospital in Patpatganj, New Delhi. Besides her academic experience has been in clinical and business role in heading laboratory operations of a large-size lab in a tertiary super specialty 500-bedded hospital, led to expansion of laboratory services to zonal regions of East Delhi for the processing of samples, maintain their quality indicators of MaxHub, a vertical of Max Health Limited. She has expertise in all departments of laboratory medicine, hematology, biochemistry, immunology, serology, clinical pathology, cytopathology, histopathology, microbiology, mycobacteriology, mycology, molecular biology, management of laboratory functions, including monitoring, auditing, as well as quality functions in all departments. Her current interest is that she's postgraduate diploma in healthcare management in 2024, ICP from Kaho, March 2023, Executive Health Management, November 2022, External Assessor of ISO 15189 2012, November 2019, Certified Trainer for NABH 5th edition in 2021, Certified in Infection Diseases by Hinduja Hospital, Mumbai 2014, Fellowship in Infectious Disease by Shia in 2014, Certified of Infection Control by Asia Pacific Infection. So she's both an administrator and a clinical microbiologist.
Thank you so much, sir, for such an introduction. I'm honored to be here by Dr. Rattan sir and Dr. Parna Jairam, and I thank Kaho and JMitra for putting me as a panelist. Thank you so much, sir. Thank you.
The second panelist we have is Dr. Abhinav Verma. He's Principal Consultant and Head Department of Transfusion Medicine, Max Super Specialty Hospital in Vishali. He's postgraduate in clinical pathology with fellowship in hematopoietic stem cells, transplantation and apheresis from St. George's University Hospital, London. His academic achievements and experiences are BMJ Research to Publication course from University of California, San Francisco, received Award of Excellence by ISBTI, that's Indian Society of Blood Transfusion and Immunohematology, Young Quality Achiever Award by CAHO, GEM Award of Clinical Excellence, Seva Bhav Award, and Suchitra Award in recognition for exemplary performance towards academics and publications by Max Healthcare, Quality Beyond Accreditation Award by AHPI, receiver of Best Oral Presentation and Best Paper Presentation numerous times, published numerous papers in various national and international journals, and Blood Center NABH Assessor, reviewer of Global Journal of Transfusion Medicine, and editor of Max Medical Journal. And so today's topic, so we can stop the sharing of slides and be live.
Thank you, sir.
So, Dr. Abhinav, let me start with you. As a person intimately concerned with blood transfusion, what is the available infrastructure and what is the magnitude of work? You should speak not only for Max, but also for other blood centers all over India.
Yeah. So there are approximately 4,000 plus blood centers all over India. And most of the blood centers in India are standalone blood centers, means they are not attached to any hospital. And very few are attached to the hospital, which are called as hospital-based blood centers. So the quality of, we can say, the blood components and the infrastructure is well developed in the hospital-based blood centers, which are mostly in the urban area. And in the rural area, basically, there is not good infrastructure, but still there are many good blood centers which comply with all the standards of testing, manufacturing, and supply of all the blood components.
I was told there is shortage of blood donation. Is that so?
So yearly there is approximately 1 to 2 million shortage of blood components in India. This is mainly because there is very less voluntary blood donation, except in standalone blood centers, which basically conducts all the blood donation camps. So the voluntary donors are more in the standalone blood centers, but in the hospital-based blood centers, there is more of replacement blood donors and very few voluntary blood donors. So that's why there is a shortage. There is a gap of nearly 1 to 2 million units every year in India.
All right. So, Dr. Suchitra Jain, what regulations need to be satisfied to run to have a blood bank or blood center inside the hospital?
So the regulatory framework in India is about Drug and Cosmetic Act, that is 1990, the National Blood Policy of 2002, National Blood Transfusion Council, that is NBTC guidelines, and National AIDS Control. So these NACO standards, these comprehensively, they are the regulatory formers in India, and they have a mandatory screening of blood, donor blood of, we will talk about HIV, hepatitis C, syphilis, and malaria. And these, there are certain additional guidelines which may follow by certain centers, but not mandatory nationwide, like for nucleic acid testing and your pathogen reduction strategies and bacterial contamination. There can be certain, which all comply by WHO framework, sir. So these are the mandatory regulatory framework in India, which we are using for most of the blood bank centers.
So would it be right to say that the blood bank blood centers are tightly controlled and regulated in the good centers and all over India, or only in good centers?
So basically, there's a difference between the good centers, we can say, or privately, many good names, we can say, like Max and many others contemporary. But yes, there is a difference between urban and the rural area, which we have. In terms of kind of assays they are using, but yes, the regulation is there in most of the urban centers. Still a lot to be done for the rural centers, I think so.
Okay, we'll tease out that later.
Mhm.
And Dr. Verma, what is the recent development in collection of blood? You mentioned that we are 1 million short. Is it about 15 million is the requirement, or 16 million units are the requirement, and we are 1 million short?
Yeah, that's right. So
And what is the recent development of correcting this deficiency?
So recent development has been that we are switching over from the whole blood to the blood components. So earlier we were collecting, most of the centers were collecting the whole blood units, and that single whole blood unit can be utilized for only one patient. But now we are moving from whole blood to blood components, and we are separating into three components, that is the red cells, platelets, and plasma, so that a single unit can be utilized for three different patients. So after collection of one unit, we can cater three patients with different needs actually. So that's how we are trying to shorten the gap of the shortage of blood supply.
Okay, that's very good. What about safety? Is there any concern that why people don't donate?
So most of their particular myths, actually, I'll say among the blood donors, that something will happen to them, they will have weakness after blood donation, or blood donation is not good. What will happen? They might get infections. So there are certain myths actually which needs to be addressed carefully and needs to be guided to all the donors so as to increase the blood donation. So that's why they still very less voluntary blood donations in India as compared to other Western countries.
Would you talk also about whether the blood has been transferred appropriately? I was told that transferring 1 unit of blood is not the right thing. If you need blood, then it should be much more. Is that right?
Transferring, sorry,
Of
sir.
1 unit would not serve the purpose.
Yeah, transferring the way I couldn't get the question, sir. Sorry.
No, sometimes the blood is used, only 1 unit is used. Is that 1 unit enough, or
Oh, okay, so you are talking about the single unit blood transfusions.
yeah?
So it all depends upon the component actually. So as I said, we have moved from whole blood to the blood components. So if, for example, if the patient's having low HB, the cutoff is 8 grams per deciliter, then 1 unit might suffice. But if, on the other hand, if the patient is having, for example, is going on a massive transfusion protocol, or there is a massive hemorrhage, then the 1 unit may not be required. They may require more units actually. So, for example, in massive transfusion protocol, every institution is having their own protocol, and we are having a ratio of 1:1:1. See, it means that if any massive hemorrhage patient comes to us, so we'll be transfusing all the three components in a ratio 1:1:1. That is 4 red cells, 4 platelets, and 4 plasma. So it all depends upon the patient's condition, the patient's requirement, and single unit may suffice in fewer cases, and more units may be required in other cases as well.
Okay. So you said that people are scared because they feel that infection may be transmitted to them.
Yes.
That is for donation, of course. Then, Dr. Jain, what is the
Yes, sir.
current mandatory pathogens that are screened so that the blood which is transferred to patients is safe? And how do you align with international standards like those of WHO?
Okay, so mandatory screening in India, as we know, this is HIV 1 and 2 antibodies, sir, antigen, and then hepatitis B surface antigen, that is the second one. Then hepatitis C, that is anti-HCV, syphilis, that is either by VDRL or rapid test, and malaria. These 5 are mandatory in India, and these aligns with our WHO international standards, and they are aligning with the core expectations. But in some cases, like malaria, it is not a mandate since it's our endemic country. We are doing it. So this is the mandated panels which aligns with our WHO core expectations.
There are different techniques available like rapid tests, ELISA, CLIA, and NAT.
Right.
Would you like to comment on them?
Yes, sir. So the effectiveness of these screening, they vary from center to center, we can say. So some of the centers, like they are using only the rapid ELISA tester, and some centers, they are using the other effective measures like CLIA and NAT testing also. So we can say with the effectiveness, if we talk about the CLIA and NAT, they are much better than the rapid test, which actually consists of the divide between the good centers and the smaller centers because of many other things. And NAT, what has happened is after the CLIA, it is more sensitive. So it is important for blood banks to have more sensitive tests rather than having specific. There are, as Abhinav will say with me, that we get a lot of false positive also in CLIA. But again, this is important because they don't have to give a diagnosis. They can throw away the blood after proper counseling. We can do that. So we need a specifically highly sensitive. Same case is NAT. If we use effective NAT, which reduces the window period, which is very important for us. If we are using rapid tests, we are not able to cover those window periods. So using NAT what will do is it effectively reduces the window period, say for HIV, we can say from 5 to 11 days versus weeks. And in case of in HPV, we get it around HCV around 2 to 3 days, and HPV around 15 to 30 days. So that is the effectiveness of NAT has taken, that the window period has been shortened in that case. So that is very important. If you want to have effective blood transfusion, we should have tests which identifies the window period also, sir, for us.
Okay, my own impression was that only 2% of blood banks have nucleic acid testing available. Is that right, or is that more are available?
No, sir, I think you are very right in saying that only 2% are there. Very few centers, they are able to have it NAT. And that is the shortcoming that we are having because we are not able to identify window period. So we should have something for that also.
There was a paper published in Nature from Egypt where they have looked at about 70 to 80,000 blood transfusions. It's a retrospective study in which ELISA, CLIA, and NAT was done. And they came to the conclusion that CLIA did not miss anything that were picked up by NAT. But as you mentioned, as Dr. Verma is also saying, CLIA would pick up it's more sensitive in the sense that it may be non-specifically positive. But since we don't have only 2% of labs, especially located in the central zones, have a NAT, would CLIA be the substitute which may be practical for India?
Of course, sir, if NAT is because it requires a lot of trained staff, we can say, and the cost is also very high. So CLIA can be used in a very effective manner in which at least safe blood donation can be done. Instead of using rapid test, I would strongly recommend CLIA platform for blood banks, not for diagnosis, but definitely for blood banks, so that we can have more, it's more sensitive. And if we even compare our results, we get very less has been positive. We have missed in CLIA. I think none, maybe 1 or 2. That is what 1 in 800 or 1 in 1,000 we missed, but otherwise they were all very comparable results with NAT, sir.
Excellent. There was another place where I read about pooling of samples, and in the West they have 16 or 20 samples pooled together. What is the position in India?
So we can utilize, since we have only these centers in urban centers, so we can say we have net technique. And in our center also, just for the experience, and Abhinav will also say, we also give it to a reference lab for testing. And if it has to be utilized cost effectively, we can use pool samples in net and then identify. But especially if there is less of HIV or HPV cases in that region. So pool samples will definitely have cost effectiveness. And then in areas where high positivity here, we can directly go for net testing. So tier testing, we can say for net, it will be an effective way of solving the issue.
And what about infections like dengue, chikungunya, Zika, uh, and Kala-Azar? Should they be screened in right places, or what is the positions? What is the statement on that?
So definitely it is not mandatory for dengue, chikungunya, Zika and Kala-Azar in India, but we do it for dengue and chikungunya. During the endemic season, we are doing is like for malaria. We also screen for dengue testing also. Since it's a laboratory medicine, we are doing it, but it is not a mandate, but still but yes, it should be incorporated if the seasonal variation is there. We should have this microbiological strong background to screen these cases also. Otherwise, because this will give into a transmission reaction, definitely.
Okay. Dr. Abhinav, what is your views on pool testing?
So pool testing, like nucleic acid testing, is available in two methods, we can say by two types. One is the ID NAT, where we are collecting a single sample and testing it. And the second is the pool, in which we are collecting nearly 6 to 8 samples and we are pooling it. So right now, the method which we are using in Max Healthcare is pool method because it is very cost effective also. And we have also got NAT yield. So I like to share my experience that in just last 1 year. So our protocol is that first we do the testing by CLIA and all the units which are negative by CLIA. So we send them for NAT testing. So out of that, we have got in last 1 year, 11 NAT positive. So it means 11 NAT yields were there, out of which 1 was even HIV and 3 was SCV and 7 was HPV. So these 11 NAT yield, in fact, if we like compare with the components, they were 33 units. So we have prevented nearly 33 patients of getting infections of HIV, HPV, and SCV. So pooling is a very good option in which in case ID NAT is not available, because ID costs a bit higher as compared to the mini pool, but it's equally effective. The NAT yield is comparable in ID as well as in mini pool.
I have donated blood in India as well as in the Caribbean. In the Caribbean, before they took my blood, they had an interview which lasted at least half an hour. In India, they take only 5 minutes and you're on, right? Is there something to do with making sure that the testing is done as the final stage rather than the first filter?
Yeah. So I'll say that the screening of the blood donors, it's very important as it serves the first line defense, and the testing comes later on. So like it is mandatory as per the Drug and Cosmetic Act. There is a particular set of questionnaire for the donors, and it's the donor questionnaire has approximately 150 questions. And these questions are pertaining to their history, pertaining to their drugs, pertaining to alcohol, their sexual behavior, and all those. So careful screening is very, very important. So whenever, for example, a donor comes to us, so he takes nearly 15 minutes to fill that form, and then later on 10 to 15 minutes, we do screen them, we do counsel them, we ask all the proper history, and then only we collect the blood. So yes, I do agree that screening is very important as it is the first line defense followed by the testing.
Okay, since you are the end user, I mean, ultimately, you are the one who is the responsible person if anything goes wrong. Now, you would be interested in doing the quality audit of the screening to see that the screening is faithfully followed. Is it done? And is it non-compliance are identified during the audits,
Yes,
internal
definitely.
audits?
Yeah, so we are doing the quality assurance program. We have got three types of quality assurance program. One is in our blood center itself, in which we run the daily controls, the daily positive controls and negative controls of after each test. The second is the inter-lab comparison. Since the parallel testing is also been done of HIV, hepatitis B and C in the lab, so whenever our test comes positive, we also run it simultaneously with the lab just to check out that what's the reading and whether our machines are working fine. And the third type of comparison is the external quality assurance program, that is the EQUAS, in which we have involved with the external center, and they do send random samples for HIV, hepatitis B and C. And I am proud to inform you that since last 12 years, all our EQUAS programs have given us full marks. So we do regular checks each and every steps, whether it's our internal controls, external controls, internal lab comparisons, or external quality assurance programs.
Very good. Okay, so we know now that we have shifted to voluntary blood donors, and now there is no paid blood donor available. So, what is the strategies to be used to promote voluntary blood donation?
Yes. So time to time, we do have our in-house camps in which we call the regular blood donors. We have maintained a voluntary blood donor registers. Apart from that, there are various societies, Indian voluntary blood donation societies, who come and voluntarily donate blood. So definitely, time to time, we also organize various learning programs, various CMEs, conferences, telling them about the benefits of donating blood. And replacement donors, in the last few years, what we have seen, that replacement donors have decreased a bit as compared to the voluntary donors. More and more donors are coming up to voluntarily donate blood. In fact, in our hospital, hospital staff regularly donates blood after every 3 to 4 months. So it's good actually we are promoting voluntary blood donations. And overall also in various, we have seen that in various states of India, the voluntary donations have slowly and steadily, it is increasing as the awareness is increasing among the donors.
Very good. Dr. Jain, when you get a screen positive, uh, the blood is not to be transfused. That is fine. So what is it that is done with the blood?
Okay, so when we currently handle transfusion transmitted bacterial infections, as we know, sepsis and syphilis, sepsis also. So what we do is usually ask the blood is definitely not given, but we have to do a mandatory counseling these days, so that the donors, they are not repeatedly, if they're not aware, they will go somewhere else and donate the blood. So the blood has to be autoclaved. There's a policy through biomedical waste management rule that blood needs to be autoclaved and then only given to an external vendor. And the counseling has to be done to whatever the reactions come positive to the donors. This is a mandatory guidelines which has come up now for transfusion transmitted bacterial infections. And yes. And
so are additional tests done?
Yes, sir. Just as syphilis, definitely VDRL and TPHA need to be done, and that is mandate for. And for bacterial contamination, sepsis risks, the platelets needs to which is the main concern for us. They support bacterial growth, so we usually do bacterial culture testing for them. Automated blood cultures or culture bottles can be used for them, and we should also do red cells and plasma. They have lower bacterial risk due to cold storage. So manufacturers, usually what we do is we do a lot of surveillance cultures in our blood bank to prevent anything from these kind of infections.
Okay, so what are your views on using of point of care testing? I think you mentioned in between that is not sensitive enough, but what would be now we're talking not from Max Hospital point of view, but for the whole of the country.
Right, sir.
When they use point of care testing, what should be the positive points and what are the negative points they should keep in mind?
So
Pros and cons.
Right, sir. So point of care testing advancement, they should be integrated in blood services. I think nobody's denied that, but how to use it, that is important. So rapid test, molecular cartridge system, sample in, they can be used. These are compact devices that can run NAT for HIV, HPV, HCV, and also have written results in 30 to 90 minutes. And then what will happen is it's just going to decentralize the screening method, and we can have better screening methods all over. Then the other one which can be used is a LAMP method platforms. They are cheaper, simpler, and also training is much low complexity settings when we can use. Then the other centers like rapid bacterial detection kits for platelets can be used. Then portable low cost other methods. Then now, as you know, the technology is advancing, we can have smart face readers. So what will happen is, what we need to do is, so we have to now disintegrate from some certain referral centers. If point of care testing is being promoted, we can have better screening methods, and we can also have pooled and mini molecular testing in that case. So if we integrate our point of care testing technology with blood banks, it's going to, with regulatory and training plan and cost model, we can have better services for our blood banks, definitely, to prevent these infections.
And how does National Blood Transfusion Council collaborate with microbiologists to upgrade guidelines on pathogen screening in response to new threats?
So there are existing collaboration mechanism, as you are aware, that we can have expert committees and subgroups are there. With time to time, they advise NBTC for the transfusion physician. So we should have transfusion physician in that, microbiologists, the virologists, public health specialists, blood bank managers, who should be drafting and upgrading these guidelines. So this is the existing collaboration methods, usually a common structure. We have a lot of consultations and workshops which goes on. Now, what we need to do is, this needs to be data driven to in parts, and it is happening, but not actually. So what the recommendation I would suggest is formalize a standing microbiological advisory panel, so that we have which have public health professionals as well as clinical microbiologists for outbreaks which are happening, which is important. Then sentinel surveillance network should be there to help these blood transfusion infections. Also, certain joint SOPs and validation frameworks can be made, and a lot of data sharing needs to be required. And definitely incorporate our microbiologists with hemovigilance committees, which is still not so happening in our country.
Yeah. Okay, Dr. Abhinav, how is the surveillance of transfusion transmitted infections tracked post-transfusion? And what data sharing mechanism, as Dr. Jain mentioned, is available between hospitals and blood centers?
Yeah. So as we mentioned earlier, that a few tests are important as per the Drug and Cosmetic Act and the National Blood Transfusion Council. That is HIV 1, 2, hepatitis B, C, malaria, and syphilis. So the first test that we do, of course, is through CLIA. And if any units are coming negative by CLIA, we send them for the NAT testing by pooling testing. And once the units are positive, we discard them, and then we counsel the donors accordingly. And it is mandatory to send each and every donor for proper referral. For example, if there is HIV positive donor, we referring them to the ICTC center, that is the Integrated Counseling and Testing Center, which is attached with every government hospital. If it is syphilis positive, we are sending them to the STI clinic, which is again attached to the government hospital. And if it is hepatitis B and C positive, we are referring them to the gastroenterologist. So in that way, the sequence is being completed from once the blood donor donates blood till the discard is being done.
Okay, and what training programs are available for transfusion medicine consultants and microbiologists on the latest pathogen detection method, and how can they be expanded so that people from periphery can benefit from the update information that is available with you?
So time to time, there are various CME conferences are being held, and also various national hemovigilance program, which is in India. They are conducting various workshops, both for the blood center managers as well as for the clinicians. There is a national hemovigilance program which has got two parts: donor hemovigilance. If there is any donor reactions, all the blood centers have to report them, and there is also the patient hemovigilance. If there is any reaction, so time to time, these workshops are being held in various places, and State Blood Transfusion Council also conducts various lectures and through virtual workshops also and offline workshops also for all the clinicians and as well as all the staff who have been working in the blood centers and hospital-based blood centers.
Okay. Dr. Jain, now as an administrator, what is the indicators you use to say that your blood bank is running well and you are satisfied with the performance of your blood center?
I think, sir, the first is that we need to have blood bank screening rationalized, where mandatory, which are done by mandate by law. They all should be performed in the national and international guidelines. Then the methods which are used needs to be balanced. Then nucleic acid testing, we are doing it rigorously for each and every donation which we are getting. And we want to, as a clinical administrator, since you're asking, I think about how the cost effectiveness influence happens in this case and how we can cater to large population. I think we have to balance affordability with sensitivity. So testing strategy has to be tiered in sense that all the blood centers should have mandatory screening, and then a pool net can be make up in pools of 6 to 8 samples, definitely. And then we should go for risk stratification, reasoning that in prevalence wise, we can prioritize our net screening. And to balance, we should have universal safety goal, affordability should also be integrated along with it. So there has to be a first is law mandate, which is mandatory. We should be doing it. The methods which are available, we can help her by pooling in less resource center.
Okay, Dr. Abhinav, recently we had a news from Japan about blood substitute, which could be given to all blood types. Could you elaborate on that?
Yeah, so that is called as artificial blood, and it is still in progress. It's also apart from Japan, it has been also been worked upon in many European countries. And once it is in the market, actually, and all the clinical trials are over, so it will be very, very helpful. Apart from the blood types, it will be acting like a universal blood type. So we can transfuse to any patient. Secondly, most of the other transfusion reactions, for example, due to donor plasma, like allergic reactions or any other infections, will be minimized. It's very, very it will be very rare that a person is getting allergic reactions due to the artificial blood. Cross matching will not be required because it will be of universal type. The clinical significance antibodies will be not be there, so it will be very, very helpful. But I think it will take some time to come into the market. And the second factor which I am concerned is that it will be very costly because artificial blood it's not being prepared so easily. So definitely, but it will help the mankind, and it will also cut short our requirement of blood, voluntary bloods or replacement bloods in the hospitals as well as in the blood centers.
So till the artificial blood is available, we still depend upon human beings to
That's true.
donate blood. So
Yes.
what message would you like to give to the youngsters that they should donate blood, and how frequently can they donate blood, and which is the age that is suitable for donating blood?
Yeah. So, as per the recent amendments in the Drug and Cosmetic Act and the National Blood Transfusion Council, so the age at which a donor can donate blood is from 18 to 65 years. And if he has donated blood before 60 years of age, then only they can extend to 60 to 65. Otherwise, it is 18 to 60. It means if they have ever donated in their life less than 60 years of age, they can still donate till 65. The frequency interval now has been revised that it is 3 months for males and it is 4 months for females. So they can donate blood, and there are various advantages of blood. Lots and lots of studies have been done regarding the benefits of blood donation. One of the first benefits that it reduces the cardiovascular attack risk. It reduces the strokes. It reduces your LDL. It increases rather than your SDL. You feel more refreshed, rejuvenated because the fresh blood is being released from the bone marrow. And recent studies are linked up that it also reduces many cancers also because it reduces the free radicals in the blood, such as the prostate cancer, the stomach cancer. So lots and lots of studies are being done in regarding the benefits of blood donation. So there's lots of uses, and one should donate blood regularly. As I said, it is 3 months for males and 4 months for females.
Excellent. Your closing thoughts, Dr. Jain?
I think the preparatory for future is very important, sir. But we are having a lot of in urban and there is a rural divide, so we should try to actually lessen that divide firstly. The secondly, as we have seen in COVID, we should be prepared for any calamity, and blood becomes very, very important component as we have seen it. So there should be stricter policy governance rules for contingency protocols for pandemics, and definitely surveillance and early detection along with deferred criteria needs to be maintained. So that is the future we are looking for blood bank, more safer blood, and more transfusions, more donations. So with the awareness program, so that people are coming forward because they know that you are able to have a safe transfusion and the blood is available to the needy whenever it is required, I think.
Excellent. It's been a pleasure having both of you to explain how safe it is to transfuse, to collect blood and transfuse blood, and how much work goes behind making sure that all the regulations are followed. I thank you for your presence today, and thank you very much. So I'll hand it over to Dr. Arjun Mahajan to give a vote of thanks to you.
Thank you very much, Dr. Rattan. You have done something which nobody has done for me right now. You've made me a doctor. Thank you very much, sir. I appreciate that. Dr. Jain, Dr. Verma, and of course, Professor Rattan, thank you so much for your inputs on this subject, which is extremely very close to our heart and something that we study and work on regularly. In fact, the thought of ID-NAT and mini pool has already been discussed as how it can be taken forward into the next generation testing of TTIs in the blood centers. And Dr. Verma, like you said, there are 4,239 blood centers in the country today. And a majority of them today are they are small blood centers, right? They have a workload of less than 300 bags in a month. And I believe, it is my thought here, that there is very little being done to enhance their level of testing. Most of these centers, Dr. Jain, Dr. Verma, they don't have CLIA.
That's true. They are still on rapid cards. Yeah.
They're still on rapid and on ELISAs. Their entire collection of blood is voluntary-based, camp-based blood testing. So if they cannot, and this is a heavily regulated sector wherein they cannot actually break even. So what happens is then they lose out in terms of the quality and the testing to the bigger centers in urban areas. Just a thought before you close out here, and vote of thanks, how can we help them as a medical fraternity, as CAHO is here, JMitra is here, we are all involved in blood centers up to our necks. So what is it that we can do, in your opinion, right? We're not making government policy here, but what can we do to enhance their level of testing and make them more able to compete with the bigger chains? Any thoughts on that?
So, Abhinav, your answer, then I will go ahead.
Yeah. So I'll suggest like we are a hospital-based blood center, and we are having all the good infrastructure. We are having all the latest equipments for NAT testing, for CLIA. So we can help the smaller blood centers who are lacking with this. We can collect the samples from them, run it on our machine, and then it is going to help them really, because the costing of the NAT machine is very high. The costing of CLIA, in some they cannot afford the CLIA also in very standalone blood center. They're still on ELISA. So we can come up with that we can support them in the testing part. And secondly, we can also run the external quality, like quality assurance programs. We can check the quality of the blood that they have been collecting. What's the hematocrit level? We can also do the culture. So in that way, we can support them in maintaining the quality assurance and in the testing part as well.
I think what is more required is bringing rural area to the urban area. More awareness first needs to be created that safe blood is required. And if we have that pool of blood, we can pool it again and do a lot of duplicates in testing, right? We can pool it in so that it becomes cost effective for them also and for us also. So our goal should be as a team to have every transfusion should be safe. That must be our goal. And for that, it should be a combined effort, definitely from policy driven. But as a team, what we can do is we can pool in that blood and go get it done for them. That is what is required, I think. Bringing them to a level, more awareness, more training programs, more affordable, like JMitra, you're there, more affordable kind of a technology which is available, like Sir said, point of care testing, which can come, which is affordable to them, less of trained personnel required. Look, syphilis was successful because we had RPR method, no molecular microscopy needed, no trained people were needed at that time. So we need to bring these things as a technology advancement to the people, to the blood centers, which can make it affordable to them. So affordable pricing will make more safe blood, I think.
Thank you.
So your thoughts?
Yeah, thank you. Professor Rattan, you were the moderator, but sir, we need your opinion on this as well.
I think Abhinav mentioned a very good method that they're doing. So the best would be that we write up the best practices which are practical and suitable to India.
Yeah.
And then handhold smaller centers. First is also to show them how much risk is there by what they're doing.
Yeah.
And once the risk has been identified and they also appreciate, help them and improve. Because helping each other will help us to make life safe for everybody.
Yes.
Thank you, Doctor. We are also committed to the same, this bottom of the pyramid when it comes to the blood centers. We are also extremely well committed to it. And over the next few months, you will be seeing certain changes, which I can commit to, wherein this particular section of the blood centers, which is the extremely small blood centers in tier 2 and tier 3 cities, or actually tier 3 cities more likely, will also be covered with CLIA testing, right? And because we are going to be giving them HIV, hepatitis B, hepatitis C, and syphilis on a CLIA platform. So,
okay.
Well, we are also looking forward to that. But today is not about that. Thank you, ladies and gentlemen. Your discussion points were very to the point, sir, and actually got feedback that this was a very interesting webinar, very engaging, and very relevant webinar. So thank you all. And Dr. Jairam and the team at CAHO, thank you for partnering with us. We look forward to more such partnerships moving forward. And Dr. Rattan, as always, grateful to you for your time and effort, sir. And all the best for the event in the evening.
Thank you.
Thank you. Thank you so much. Thank you, sir.
Thank you so much.
Thank you, Carl. Thank you, Carl. Thank you, sir. Thank
Have
you.
a good weekend. Jai Hind.
Thank you.
Thank you, sir.
Thank you, Pramodji and Akshita.
Thank you.
Okay.
Thank you.